It's okay with you. We'll go ahead and get started. So, good morning, everyone. It's my distinct privilege to introduce Dr. Neel Bhatt as our departmental grand round speaker this morning. Dr. Bhatt is an assistant professor in the Department of Otolaryngology Head and Neck Surgery at the University of Washington. He completed his undergrad and medical training at Indiana University, pursued residency at WashU, where he completed a T32 research fellowship, and then he completed his fellowship in laryngology at USC. Dr. Bott's experience is in neuromuscular changes to the larynx with aging and neurodegenerative diseases, and he's actively working to develop novel therapies for vocal fold atrophy. He's an accomplished academician, having published over 50 research articles, and for his work, he's received multiple grants, including the Triological Society Career Developmental Research Award, the American Laryngological Association Postgrad Research Award, and as a testament to his investment in resident development, his resident mentee has won two consecutive core grants for his related work. And he's also developed an app for quantifying vocal fold atrophy. So today, Dr. Bott will be sharing his expertise on neuromuscular changes in aging larynx. Thank you so much for being here today, Dr. Bott. We very much look forward to learning from you.
Thank you for that great introduction. It's a real honor and pleasure to speak with you all this morning. Thank you so much for the invitation. Um, like I said, my name is Neel Bhatt, one of the laryngologists at University of Washington, and I'm speaking with you today about an area that's really near and dear to me, the aging larynx, and understanding the changes, clinical considerations, clinical challenges, and areas of research. So my hope is that I'm able to blend the clinical challenges with some of the research that we're doing at University of Washington. When we look at the larynx, we're synthesizing a lot of information simultaneously. This is a very reassuring exam, not an individual with age-related vocal atrophy, but we can see things like closure, vibration. But that is a good comparison to something like this, which this individual, they have the diagnosis of age-related vocal fold atrophy or presbylarynx. And you can see clear things like bowed vocal folds, incomplete glottal closure during phonation, sometimes some thick mucus and secretions, a lot of supraglottic hyperfunction, muscle tension, probably secondary to some of the insufficiency. But clinicians, expert clinicians, laryngologists, non-laryngologists can understand visually that in the proper clinical context, there are clear differences between the two. And there are clear features. The vocal fold bowing. So on the left, you see non-age related vocal fold atrophy. You see the clean, straight vocal fold free edge, compared to the right, where you see the vocal fold bowing, atrophied, hollowed looking vocal folds. And so, despite maximal effort, for example, you don't quite get the valving at the larynx, and that can lead to this breathy, sometimes rough, hoarse sound. So the features are well described, and things like increased bowing, sometimes quantified with things like the bowing index, normalized glottal gap area, reduced normalized mucosal wave amplitude. These are features that we see clinically and often described in the research. And the impacts are real. Um, Literature shows that individuals have a reduced quality of life. They're often socially withdrawn. And as a result, it has a big impact on health and, impacts health utility. It is a fairly common diagnosis. So, in large studies looking at tertiary care academic centers, it's estimated that 1 in 3 individuals over the 65 have a diagnosis of age-related vocal fold atrophy. And it goes to show that it's a big population and new treatments, new advances could have a dramatic impact. One of the challenges, though, and this was a common theme with today's presentation, is that unfortunately, this diagnosis is highly qualitative. And while there's tremendous value in being able to describe the changes and at present state, it's a very important way to diagnose the condition. I think it presents challenges for both research, um, clinical care, rating how a patient does with the various treatments. My definition of vocal fold atrophy may be very different than Dr. Rosen's definition, and as a result, we may have differing opinions about the severity and whether someone has responded to treatment. This vocal fold atrophy or vocal fold bowing, for example, is observed in other conditions. So things like Parkinson's related neurodegenerative vocal fold atrophy, we can see things like bowing. And so I think having a precise diagnosis could be a helpful thing, not only in differentiating conditions, but perhaps maybe even an early indicator of other non-aging related vocal fold atrophy. And I think baked into all of this, one of the real challenges is that there is a co-prevalence of presbycusis or age-related hearing loss. And it fits into the big umbrella of communication difficulties. And so, one individual might not be able to hear, their partner may not be able to speak loudly, and that overall communication arc is severely impacted. Of course, a lot of research in age-related hearing loss, and I think age-related voice loss and change challenges, I think, are a worthy cause of support. So, as I look at the clinical picture, I think that there are three principal challenges. Number one is that the neuromuscular changes, what's driving this vocal fold atrophy bowing, not well understood. Like I mentioned, that the diagnosis is often qualitative, that there's no real hard numbers to describe what we're seeing. And that unfortunately, the treatment success is often variable. So, highly motivated patient, signs of vocal fold atrophy, we prescribe a treatment, whether that's therapy or procedural interventions, really optimistic about the outcome. And unfortunately, it doesn't translate to substantial improvement in the voice. I think one of the really key points, in this work by Doctors Gardner Schmidt and Rosen is that there is a high variability in what treatments patients elect to proceed with. Some patients want reassurance, likely that there isn't anything else besides aging, atrophy of laryngeal muscles. Other people, perhaps with more perceived voice handicap, are interested in procedural or therapy options. But it goes to show that part of the decision making is really based on how the patient feels, how impacted they are with their voice condition. It could also be that perhaps the treatments that we have are not as slam dunk of treatments, and for some individuals, it may not be enough to motivate them to want to try a treatment. So I think that's an area to better flesh out. We wanted to see what's the health utility or the quality of life detriment with age-related vocal atrophy. And so in our institution, we looked at patients with vocal fold atrophy and found that age-related vocal atrophy had a health utility comparable to monocular blindness, anchor point in rating health utility. Another thing early on, we wanted to see what are the high quality studies out there, controlled studies looking at various treatments for age-related vocal fold atrophy. And surprisingly, maybe not surprisingly, there aren't a lot of controlled studies comparing different treatments for age-related vocal fold atrophy. Big picture, there is therapy and there are procedural interventions like injection laryngoplasty to augment the vocal folds, bilateral type 1 thyroplasty, also with the idea of augmenting the vocal folds to enhance closure, add bulk to the vocal folds. There are other treatments, but those are two principal big areas of treatment. But in this systematic review, we found there really was no consensus treatment. And some of these studies compared different types of therapies, different types of procedures, and even therapy and procedure. And it goes to show that it's sometimes difficult to predict which patients are going to experience meaningful improvement. This is an individual with the diagnosis of age-related vocal atrophy. You can see what I would call, mild vocal fold bowing. There's sometimes touch closure, sometimes incomplete, but based on his presentation, was impacted by voice. After therapy, he was very motivated to continue treatment, and so we augmented the vocal folds with a temporary filler, hyaluronic acid. In this case, the patient did experience meaningful improvement and wanted to proceed with a more durable option. And so we elected, based on the improvement with the augmentation, the temporary filler, to proceed with type 1 thyroplasty. And you can see that the vocal folds have a more plump character, that concavity, the bowing is not as clear. But while this patient experienced improvement, and you can see endoscopic signs to corroborate this, this is not always the case. And part of the reason is that treatment success is sometimes very difficult to predict, at least from my vantage point. Um, Looking at the endoscopic laryngostroboscopic assessment may be helpful in that if individuals experience a profound amount of glottal incompetence or incomplete glottal closure, perhaps those are the individuals that would be most likely to benefit from procedural interventions. And I think ultimately interdisciplinary care in these patients is very critical. While we can change things at the larynx, the organ, augmenting the vocal folds, actualizing those benefits with really strong speech pathology partners is a really critical thing in the overall care for these patients. In a lot of patients, their main motivation is to make sure that there is nothing else that, like a dysplasia, something on the vocal folds that might explain the voice changes. I do think, though, that empowering patients with the idea that perhaps there are treatments that maybe aren't traditional treatments but could prevent vocal fold atrophy in the future seems to really resonate. And while this is an area of ongoing research, some studies do suggest that lower BMI, lower muscle mass may be associated with increase in vocal fold atrophy or presbylarynx. And so part of my explanation of the condition and perhaps reassurance with patients is that maybe they have some control over this. And so I'm very encouraging of, things like light muscle resistance training, overall health, and using the voice safely and as much as possible, perhaps like any skeletal muscle, to prevent atrophy from happening. So when we look at this clinical challenge with sometimes difficulty in predicting which patients get better, part of my research is to identify, can we precisely identify what neuromuscular changes are happening in the aging larynx? Can we develop objective measures to quantify vocal fold atrophy? And with the first two questions answered, perhaps we can more thoughtfully propose treatments for this condition that may outpace, be better than current treatments. And so, kind of taking a real step back in residency, was lucky to work with Dr. Randy Paniello at Washington University, and mostly in animal models, we were stimulating the recurrent nerve, learning information about recovery, perhaps things like enhancing selective adductor recovery after injury. This was a really eye-opening experience for me because this was providing numbers to innervation, providing real solid metrics that we could compare injured recurrent laryngeal nerves from non-injured nerves. And at the same time, really ongoing research with turns analysis was also really exciting. Dr. Rosen and colleagues looking at the change in muscle polarity with volitional recruitment of muscles in the larynx was one of the first measures to quantify innervation. And so it provides this idea that perhaps a threshold of turns per second could predict recovery, could predict improvement in voice and vocal fold motion, and provide a working definition of synkinesis, which is the aberrant reinnervation of adductor and abductor axons following nerve injury. And for someone new to the field, this was music to my ears because now this is providing some numbers that elevates perhaps the analysis of vocal fold atrophy or recurrent nerve injury beyond these qualitative measures. But because we were working with animal models, we really focused on the evoked response, which, unlike the turns analysis or quantitative EMG, this involves electrical stimulation of the motor nerve and then measuring the evoked response at the target muscle. Now, this is common in the workup, management, diagnosis of a lot of peripheral nerve injuries. Things like brachial plexus injuries, carpal tunnel syndrome, spinal cord injuries. Motor evoked responses are frequently performed. And so, just very briefly, the motor nerve is stimulated, and you get a compound motor action potential. Some of these axons travel at variable rates and depolarize the muscle fiber at variable times, leading to this temporal summation known as the compound motor action potential. And the compound motor action potential is essentially the algebraic sum of action potentials at the target muscle, and in this case, the laryngeal muscles. And so early on, we could measure things like the area under the curve representing the total innervation, or at least near the active electrode. The peak amplitude, so somewhat of the coordination of the muscle depolarization. The latency, or the interval of time between electrical stimulation of the nerve and when we see the first action potentials, and the duration. So comparing the fastest nerve muscle propagation impulse with the slowest ones. And things like demyelination, for example, one would expect an increase in the latency. If there was selective demyelination, there might be a splaying in the duration. If there was a loss of axons, one might see a decrease in the area under the curve in the peak amplitude. So this provides some information about what might be changing in the neuromuscular junction, and the muscle. And so early on in residency, and I worked with Dr. Andrea Park too as a co-resident. We were doing some of this work comparing injured nerves with non-injured nerves, and found things like CMAP duration and latency to predict previous history of nerve injury, and was good at discriminating between a nerve that had been previously injured and a nerve that had not been injured. And so, because of this work, it really led me to this idea that perhaps we could apply this measure to understanding what's happening in the aging larynx. And so, my lab is really focused on two aims, and that's understanding these muscular changes in aging rat model, but also human studies. Some of those in patients undergoing a laryngectomy, where we have the opportunity to collect nerve, muscle, and do the same neurophysiologic testing. The nice thing about the animal model, it's very tractable, manipulatable. We can do lots of experiments to understand these changes and see what overlap exists in the aging human larynx. So our recurrent laryngeal nerve studies, like I said, use the aging rat model. Aging rat model is great in that the larynx um, has similar nerve muscle control. Vocal folds come together during voice production, swallow, respirations, adductor reflex, and you can simulate conditions like, for example, here we see left-sided recurrent laryngeal nerve injury and a unilateral paralysis. And we can also get very high definition views of the larynx. And so in this case, we're stimulating the nerve and getting a laryngeal adductor reflex. Um, Unlike the human larynx, the arytenoids are quite large. The membranous vocal folds you can see on the top part of the screen are relatively small compared to the human larynx. But very similar laryngotracheal complex. So A is the larynx, B is the cricoid cartilage, C is the trachea, and the two asterisks are pointing to the recurrent laryngeal nerve. And so early on, similar to what we had done in previous animal work with recurrent nerve injury, we began stimulating the recurrent nerve in the animal model and measuring the compound motor action potential. Secondary measures are things like the motor unit number estimate. So we stimulate at sub-threshold levels to look at the number of motor units, and then stimulating the nerves at different locations to understand the speed of the nerve conduction, or the nerve conduction velocity. In our early work, we found that in the aging rat, at 21 months compared to 4-month rats, now these are adult rats, but the 21-month, pretty aged animals, that these have an increase in the CMAP latency. And We also wanted to quantify whether there are endoscopic changes. When we visually inspect the vocal folds, is there an increase in things like the bowing index or the degree of bowing of the vocal folds? And while ongoing work is really trying to precisely estimate what's the difference, our early pilot work suggests that, like the human, um, the aged rat larynx also shows signs of vocal fold thinning, bowing, and so this may be a useful model to study new treatments. And then at the same time, we're quantifying nerve and muscle changes too. And so you can see in A, this is a cross section of the recurrent laryngeal nerve in the rat. C is muscle, and then we can quantify things like myelination, axon count, and then for the muscle, we can look at the cross-sectional area and diameter to understand whether how muscles are changing. And in some of this work, we have found that there appears to be a decrease in the myelination, explaining why there's an increase in the latency. Myelination may help enhance nerve propagation of signal, and it appears that there is a decrease in the speed, perhaps secondary to decrease in myelination. In terms of the actual muscle changes, we were surprised to find out that the cross-sectional area in our aging rats actually increased. Uh, and, we would expect based on the endoscopic changes that that would have gone down. So this is an area of ongoing research, and we're very excited to corroborate some of the neurophysiologic endoscopic changes with what we see from histology, perhaps providing some mechanisms as to what we see occurring. And, it may provide some treatments down the road that we can test in the animal. So motor dysfunction or motor changes is one thing, but clearly in the aging larynx, there is a decrease in sensation in the larynx too, which one could argue is, perhaps equally, maybe even more important. Aspiration pneumonia is a leading cause of mortality in the elderly, and in some of those cases, it may be secondary to decrease the sensation at the larynx. And there have been researchers like Dr. Sulika et al. Looking at ways to quantify sensation. And in this case, stimulated laryngeal mucosa measured the reflex arc with the laryngeal adductor reflex to provide some numbers as to how this reflex arc works. Um, Group here, Dr. Ma and colleagues, which again, following that theme of quantification of things that we often don't quantify, um, measuring the tactile stimulation, the percentage of individuals that experience a response. An interesting study showing that as individuals age, that sensation tends to decrease. And because of our work with the animal, we wanted to see if we can measure these same types of changes in the aging rat larynx. And so you can see here, this is on the right, this is the superior laryngeal nerve, and you can see the branch point into the internal and external branches. The circle on the left is the cricothyroid muscle, which is innervated by that external branch. And similarly, we can measure things like the laryngeal adductor reflex with stimulation of the superior laryngeal nerve. So here you can see a micro cuff electrode around the internal branch of the superior laryngeal nerve. And we can stimulate the superior laryngeal nerve at the asterisk and measure a compound action potential. So not a motor action potential, but a sensory nerve action potential. Because of the sensory nerve, somewhat smaller amplitude, we tend to average the response over 10, 20 stimulations. And you can see this nice curve on the left showing this compound action potential. Because of these small nerves, we typically will sever the nerve afterwards to confirm that the signal that we're picking up is truly from the superior laryngeal nerve. And we can also stimulate a swallow reflex and a laryngeal adductor reflex by stimulating that internal branch. So in our work, we have found, similar to the motor studies, as the rat cohorts age, there appears to be a splaying in the latency. And the latency is the time between the stimulation of the nerve and when we can see the first action potentials. And so as the rat cohorts age, there appears to be a splaying or a slowing of that nerve conduction and an increase in the total duration. And so that also suggests that there may be demyelination occurring. We also measure the compound motor action potential at the cricothyroid muscle. So similarly, we stimulated the superior laryngeal nerve and measured the compound motor action potential. And similar to the work with the thyroretinoid muscle and stimulating the recurrent laryngeal nerve, we found similar types of changes in the compound motor action potential too. Interestingly, though, while we are seeing changes in nerves, um, it's difficult to, at least at this point, see clear changes in things like swallow force, swallow mechanics. So we are measuring things like hyoid elevation, the force of hyoid elevation. And so I think one of the important things as we move forward with our research is while we are observing neurophysiologic changes, observing changes in things like vocal fold bowing, I think it's important to make sure that we can see functional changes too, which at least in our work with measuring swallow force frequency, we haven't found dramatic changes as the rat has aged. So an area of ongoing work is similar to the motor studies, looking at quantifying things like axon count and morphology. So part of our ongoing work is looking at quantifying atrophy, excuse me, in in some of the muscles. So we're also finding that we see this type of atrophy as the um, human ages too. And excuse me, getting over a bit of a cough. But yes, we can see things like increase in Boeing index, an increase in the glottal gap area. And so part of our research is trying to measure these changes as well. And what we've found is as the Boeing increases, there's clear changes in the degree of bowing. So as the bowing increases, voice tends to get worse. We also looked at doing these studies during human total laryngectomy and found that we can measure these similar types of neurophysiologic measures also in vivo conditions. And similar to the rodent studies, we can also measure things like myelination and muscle fiber diameter and things like that. So the last area that I really want to talk about is perhaps my efforts and our efforts to quantify vocal fold bowing and vocal fold atrophy. Now, we can visually see changes in vocal fold bowing, but precisely quantifying what are those changes is sometimes difficult to do. And one of the things that we've developed is the ability to perhaps streamline some of the quantification of this. So we've developed a really very basic, very simple application that allows laryngologists, researchers, to take a picture or upload a picture of the human larynx, um, perhaps bowed larynx, to quantify things like the Boeing index. So in this case, the larynx image is taken, and in with a few placement of markers, the researcher or clinician is able to derive the Boeing index. You can upload really key metrics like age, BMI, other voice measures to determine perhaps, some correlations. One of the really nice things about this app is that the individual who uses it has the capacity to share this data with our team. And this is de-identified anonymous data. And our goal is to correlate things like age and the degree of bowing, perhaps to develop normative values and maybe correlate things like um, how does BMI, for example, how does sex play a role in the degree of atrophy based on age? And in our first year of having this app, we had about 1,500 data entries. And while this work is ongoing that we're analyzing, things like Boeing index, which is a quantification of the degree of bowing, was more in males compared to age-matched females, something that we see and expect. And one really exciting thing about the app and quantification of Boeing index is that perceptual measures like rating vocal folds as being mildly bowed, moderately bowed, severely bowed appeared to correlate with what quantifiable measures of vocal atrophy we're seeing. And, my opinion on this quantification is that while it is really helpful, it certainly helps with research. If we could say that we only included patients with a certain amount of bowing, well, now we can describe the study population a little more precisely. I still think, though, that perceptual measures, what we currently do, expert opinion, has a really valuable and tremendous role in assessing vocal fold atrophy. A static image of the larynx, while it may provide really key information, I think our brain naturally synthesizes a lot of information that is beyond just one static image. And so, my opinion on all of this is that it's an attempt to quantify things that we see, but it doesn't replace qualitative assessment. It doesn't replace our ability to inspect and analyze vocal folds. And so perhaps I'll pause here. I want to thank the opportunity to speak with you all today. I know there are a lot of topics. It's a challenging condition, but my hope is that with ongoing work and understanding the precise changes, we're able to thoughtfully present new and exciting treatments for this condition. So thank you.
Thank you so much, Dr. Bhatt. That was an incredible talk. Really appreciate you covering the spectrum of, the background and then what kind of novel approaches you're taking to try and address the neuromuscular changes in vocal fold atrophy. I'll open it up for questions if the group wouldn't mind raising their hand, and I can help facilitate. To get us started, I was hoping to ask two quick questions, Dr. Bhatt. The first is, I think in residency, we think a lot more about the bulk rather than like the muscular and the kind of the histological changes to the vocal fold rather than the neurologic component to atrophy and kind of dysphonia. And a lot of your work talks about the changes in myelination. Is there parallel work that's been done to decrease the rate of myelination? What other things can be done to kind of address that component of atrophy and dysphonia, and what kind of thoughts are going on around that?
Yeah, so yeah, that's a great question. I do think that some of my mentors are looking at things like mitochondrial dysfunction, muscle energetics, contractility. And in other parts of the body, there appears to be neuronal control for why muscles atrophy. And so it is possible that the nerve deterioration over time might be impacting how the muscle works. I hope that makes sense. And so, in my mind, things like demyelination may not be the only change, but it may be upstream to the changes that we see in decrease in bulk, tone of the vocal folds. And so I think there's an interrelatedness to it that with decrease in innervation, maybe decreased ability to stimulate the muscle, over time, there is a deterioration in the muscle function. Hope that makes sense.
It does, thank you. Yeah, I wasn't sure. I know that there's kind of thoughts about like certain like omega-3s or certain even medications that can uh
Right, yeah. And
change de the demyelination rate. So I was curious if that was something that a parallel that could maybe be explored, but it's that I was just curious.
yeah, no, and I think it's on my mind, treatments to, how to perhaps decrease myelination, but
Stream.
things like electrical stimulation may also enhance um, the muscle from atrophying too.
And then my second question for you is sometimes when I'm assessing vocal fold atrophy, one simplistic thing that I see in addition to bulk is that the elasticity changes, to the changes to the vocalis and the superficial lamina propria. And so that looks very floppy, or it doesn't look like it's really able to maintain the same sort of vibration and create the same sort of timbre. And the interventions we have right now create bulk, but they don't really, I don't know if they've been really optimized from the elasticity standpoint. So I was curious um, what can be done to better address that? Are there certain materials that are being explored? Where is there room to grow on that front to maybe rather than just projection, also improve timbre and kind of really getting back to that natural voice that I think patients want?
Yeah, that's a great question. And, the neuromuscular changes, hard to say whether it affects the vibration. Maybe not. And maybe these are changes that are happening in parallel that could have targets for treatment. It's not an area that we are looking at as extensively, but I do think there is tremendous energy studying this. Things like uh, growth factors, injectables, platelet-rich plasma are treatments that have been proposed and in some cases have shown to improve the vibratory capacity, especially in the setting of scar, which maybe not present in age-related vocal atrophy. But you're right, with the decrease in elastin fibers and increase in some of the more dense collagen fibers, maybe those same treatments could be helpful at improving the vibration capacity of the vocal folds. So my opinion is I feel like that area of research is fantastic. It should be happening in parallel, and perhaps that both treatment aims looking at the neuromuscular component and the vibration capacity, you know, probably should be happening in parallel.
Thank you so much, Dr. Bott. I think Dr. Rosen has his hand raised for a quick question.
Neel, great work. Thanks so much for sharing your efforts with us. What do we know about aging and atrophy in the rest of the body? What are other people doing to look at this, in hand musculature or rib cage musculature? And can we borrow evaluation principles from the rest of the medical world?
I think you hit the nail on the head. And, from my K and mentors, I think that is the direction. So the person who I'm working with is an aging muscle researcher, really specifically looking at how muscle mitochondrial function deteriorates. And yes, often, a switch in muscle fiber type, sometimes more the slow twitch fibers. Um, but some ongoing clinical trials are looking at naturally occurring metabolites and different treatments to enhance mitochondrial function to see if skeletal muscles can be improved. Now, aging and skeletal muscle atrophy is well studied, very common, and some of the metrics that I discussed, like the decrease in the compound motor action potential, are also found in other parts of the body. So I think the larynx has likely some special innervation rates of atrophy, probably use compared to other parts of the muscle, other parts of the body. But I think applying some of the proposed treatments for preserving muscle function in other parts of the body, uh, exogenous medications, some of these naturally occurring metabolites, it'd be very interesting to see how does that potentially prevent atrophy at the larynx muscle. So I think philosophically, that is where I'm really excited is applying what may be working in other skeletal muscles and seeing if the same improvement can occur at the larynx.
I think Dr. Young had a question next. Thanks, Dr. Young.
Um, Neel, thank you for a very comprehensive and actually very easy to follow discussion. Um, you do such great work with research, and my brain is very wired to think on the clinical front of things. You know, what I struggle with are the real life clinical scenarios where the vocal folds look terribly bowed, but the voice isn't that bad, and the patient isn't that bothered. And then there are the patients that they don't look that bad, but they may sound terrible or they may be very bothered by their voice. And we know the clinical variability, you referenced it, right? That's part of the problem um, with better understanding this issue for patients. My question is, from your research um, expertise side of your brain, how do we marry that in moving forward with research projects to investigate this further, right? There's the we can look at videos, we can look at, basic science aspects, but how do we marry in the clinical component in a way that's meaningful to guide us in clinical care?
Yeah, no, I think part of the strength of being a clinician, I think, is having a vantage point in which you're not totally have your blinders on, where you're only just focused on a animal model, for example. And I think part of my motivation, our motivation, is to simultaneously do these evoked responses in humans. And while we have not done evoked responses in awake humans in clinic, for example, there are other groups that have done these measures. And so I think number one, understanding in the human how some of these proposed changes that we're seeing in the animal really apply to the human larynx, I think is critical for the translation of this. And then treatments that may be working in the animal model, I think simultaneously testing it in humans, really emphasis on collecting nerve and muscle samples when it's feasible, I think are really important. And I also think, similar to, what I was discussing earlier, stepping outside of just larynx, laryngology, and understanding what treatments are working for other skeletal muscles, I think provide a direction in which to go. But I think your point is well taken in that, you know, there is a so what if you find all these neuromuscular changes in the rodent. But I think the real strength of clinicians, scientists, and having a real strong footing in the clinical world is being able to apply those changes, apply those findings, and see if it really makes a difference at the patient level. Hope that answered your question.
No, it's great. I have a soft spot for these patients because exactly as you said, the clinical course is variable, the treatment success is variable, and I love everything you're doing to try to help us move that forward for patients. Thank you.
No, thank you.
I see Dr. Park has her hand raised for a question. Thanks, Dr. Park.
Yeah, hey Neil.
Good to see
Thanks.
you.
Yeah, great to see you. Thanks so much for an awesome presentation. Really excited about all the work that you're doing.
Thank
My
you.
question actually kind of goes in line with what Dr. Young had mentioned, in terms of like the applicability, right? I didn't know if you're also measuring sort of like effort. I remember one of the things that, from a kind of adaptive standpoint, we talk about, how much effort and kind of bolstering up, and increasing the velocity of air, for example, or strength, when they're doing therapy. And so, how much of that do you find is correlated for patients that potentially are not bothered?
Yeah, no, I think it's critical. And even though a lot of our research is very focused on the larynx neuromuscular changes, um, I think voice is multi-level, effort dependent, breath stream, so many different factors that impact voice. And as I embark and continue with this research, strong speech pathology partners that often are thinking a little bit more holistically with voice production are really critical in quantifying effort and how well things are working. So yes, I think to answer your question, effort is a clear determiner. And sometimes patients' voice is great, but they are quite bothered by how much effort is required. And so I think that is a patient metric that is worth tracking actively as we continue with clinical trials and human studies.
Awesome. Thank you.
Thank you.
Well, Dr. Bhatt, thank you so much for coming and talking and for creating such a great discussion with our department. It was so nice to have you. Many of the residents really just appreciate it already that you're here and sending me messages. So thank you so much for being here. I really appreciate it.
Awesome. Well, it was great to speak with you all and reconnect with so many different people. And yeah, really appreciate it. Thank you.
Okay, take care.
Take care,
Thanks all.
Neel. Thanks so much.
All right, take care. Thanks. Bye.
Thanks, Neel. Bye.